welcome everybody to today's PBD. Here is Dr. Navin, who is one of the pediatric intern doctors at Narangi Hospital, who is going to present on Empyema. So, Dr. Navin, I'll hand over to you.
Okay, thank you very much, Dr. Lau, for allowing me to present this topic today here. Well, all the doctors and the medical professionals who are here in this meeting today, a very warm salutation to all of you. It's me, Dr. Navin Kumar Sharaf, and I have completed my medical schools from China Dal University and currently doing my intern in Narangi Hospital and in the pediatric department. And today I'm going to talk about the topic Empyema. So while talking about this topic, we will also going through one case. Excuse me, I can't change. Thank you. The case here is a 7-year-old female presents to the outpatient department with a high fever of 103 degrees Fahrenheit, cough, fever, and shortness of breath that is persisting for the past 3 days. And upon the physical examination, diminished breath sounds are noted, accompanied by the bronchial sounds. Now, we will follow this case during these sessions. What should be the diagnosis, what could be the differential diagnosis, and how can we investigate this case, and what should be the model of treatment. We're going to talk about that during these sessions. Okay, so here in the next slide, we are going to talk about what is empyema. Empyema is an accumulation of pus in the pleural space that can be mostly associated with pneumonia, or it can be also occur by the rupture of lung abscesses into the pleural space, or like contaminations from trauma or thoracic surgery. Rarely it also caused by the mediastinitis, or sometimes the extension of intra-abdominal abscesses also leads to the empyema. And while talking about the main etiological factors, okay, so here in etiology, the most often associated with pneumonia, the caused by Streptococcus pneumoniae, but most commonly in developing nations in Asia and as well as in post-traumatic empyema, the Staph aureus is the most common causative agent. And since the H influenza type B vaccinations is introduced, the incidence of H influenza empyema has decreased. And also group A Streptococcus, group gram-negative organisms, tuberculosis, fungi, and malignancy are less common causes of these empyema. Now, talking about the epidemiology, the empyema is most frequently in infant and preschool children, and it is increasing in frequency. It occurs in 5 to 10% of children with bacterial pneumonia and up to 86% of children with necrotizing pneumonia. Well, talking about the pathology of this disease, so empyema has 3 stages: the exudative phase, fibrinopurulent stages, and organizational stage. In these all these 3 stages, in exudative stages, the first, the exudates or the effusions are going to be from the forms on the pleural space, and on fibrinopurulent stage, the fibrinous septa form, causing the loculations of the fluid and thickening of that parietal pleura. And if that pus is not drained in time, or if it is not going to be resolved by the treatment, then it may dissect through the pleura to the lungs parenchyma, or it can also produce the bronchopleural fistula or like pyothorax, and sometimes it also dissect through the chest wall that can lead to empyema necessitatis. And the organizational stage, in this stage, the fibroblast proliferation seen, and in fibrinoproliferative stage, which the loculation has already been formed, so their wall is going to be thickened and can make abscess cavities in the lungs, which can collapse the lungs, or that may interfere with the normal functions of the lungs. Next, please. Okay, now talking about the clinical manifestations. So this empyema, the patient's initial signs and symptoms are going to be somewhat same as of bacterial pneumonia, like acute febrile response, pleuritic chest pain, cough, dyspnea, hemoptysis, and even some patients will severely systemically toxic or even comatose, or maybe cyanotic, hypotensive, dehydrated, and oliguric or weaknesses can be seen. And because of that inflammation of that pleural spaces, sometimes the patients may come with the abdominal pain and vomiting, and the patient exhibit characteristic splinting of the affected side. And the patients who are already immunocompromised, and if that patient is going to be followed, going to be suffered from these empyema things and all, then at that time the symptoms may be blunt and fever may not be present on those kind of patients. Now, the children treated with antibiotic agents may have an interval of a few days between the clinical pneumonia phases and evidence of the empyema. Now, talking about the physical findings, then the physical findings of empyema is also going to be the same like as serofibrinous pleurisy, where we see the dullness or flatness on during percussions, or we can during auscultation we can see like breath sounds are decreased or absent, or there are the diminutions in tactile firmities, and even sometimes we can hear the crackles and rhonchi during the auscultations if there is extensive pneumonia is present. And as these physical findings of empyema and serofibrinous pleurisy are going to be same, so it is very crucial for us to differentiate between the effusions, that is the serofibrinous effusions, or that is the pus over there. So for that we must have to do thoracentesis, and then if any cases is suspected that there is empyema. Well, talking about laboratory findings, so keeping that case scenario in our mind, that there were like at the beginning there was a case that 7-year-old females presented in OPD with the symptoms related as like bacterial pneumonia and with the decreased breath sounds with bronchial sounds and all. So now radiographically, how we are going to differentiate that? So first of all, I'm going to talk about the radiographic things for the laboratory findings. And in chest X-ray, as like the physical findings, where the empyema physical findings are correlated, the percussion auscultations things are correlated with the serofibrinous pleurisy. Like as here also in chest X-ray features, the all pleural effusion appears the similar of pleural effusion, as like we can see the obliteration of costophrenic angle and the fluid level plus diffuse opacity, and severe effusion may also like show displacement of the mediastinum to the contralateral hemithorax, or sometimes we can also see the scoliosis, right? But the absence of shift of the fluid with a change of position indicate a loculated empyema. And when we will do the ultrasound, then in ultrasound we can see the heterogeneous fluid collection, and sometimes the septa may be confirmed by ultrasonography, or the CT is going to be based for the septa confirmations for the septa formation over there. And when we will do the chest CT, we will see the split pleural sign, the septation, the displacement, and the compressions of the lungs and the lung tissues. Okay, so here for that cases, when we did the X-ray and the USC report came, so we can clearly see here in the first X-ray, which is on your left side here, that we can say that at the left side we can see the diffuse, yes, the diffuse opacity on the left side, and we can also see that some displacement of trachea to the contralateral side. And I'm not sure that I can say this is a scoliosis or not for the vertebra, but we can see the that opacity, and we can see the displacement of that trachea over there, and of course the costophrenic angles are obliterated, the cardiac slots are not seen clearly in this X-ray. So now by seeing this, as we discuss about that, the chest X-ray features, the physical findings, that all are going to be resembles with the serofibrinous pleurisy. So again, why it is important to do thoracentesis? Here we can see that even in pleural effusions, in serofibrinous pleurisy, the same chest X, we can see the same changes in chest X-ray, the obliteration of costophrenic angle, the obliteration of cardiac slowed and all. So how we do interpret the chest X-ray finding and the USC report, and what do they suggest about the underlying conditions? So now, as here in USC also, there is only 10 gross heterogeneous collections with multiple loculations noted within left pleural cavity, right? So in this only going through the features of the chest x-rays, we are unable to differentiate that what kind of effusion is there. Is that is the serofibrinous pleurisy, or that is chylothorax, or that is pyothorax, or that is hemothorax. It's very hard to differentiate that. And for that, we have to do the thoracentesis, in which we can easily see the colors of that fluid also. And from that, we can differentiate that it is chylothorax or hemothorax. And when it comes to the empyema, pus, or the serofibrinous pleurisy, so for that we can do the further lab investigation. So let's talk about that. Now here, the further investigations. The maximal amount of fluid obtainable should be withdrawn by thoracentesis, and examination of the fluid is essential to differentiate the exudate from transudate and to determine the type of exudate, so that we can easily find out, or we can make a one goal of treatment, that what line of treatment should be there. So for that reason, thoracentesis and the examination of the fluid, the chemical evaluation of the fluid, or sometimes the culture of that fluid is very important. In chemical evaluation, we are going to see the fluid protein level, the pleural fluid LDH level, also the pH of fluid, so that we can compare and we can talk about the ratios of pleural fluid protein and serum protein ratio, and depending upon that we can differentiate that either it is exudative or transudative. And here's one point written here, that hypoalbuminemia is often present. So sometime because of effusions happens because of either inflammations or because of any systemic causes. So if there is a systemic causes involved, then of course hypoalbuminemia can be seen there. Now here is a table of pleural effusions, where we can here are given some laboratory parameters, depending upon which we can differentiate the transudate versus exudative effusions. So going through the light criteria, the pleural fluid protein and the serum protein ratio, if that is going to be more than 0.5, the fluid LDH or serum LDH ratio is going to be more than 0.6, or pleural fluid LDH is going to be more than 200 international unit per liter, then that is the suggestive of exudative effusion. And if that, unlike the exudative effusion, if that all the things are going to be less than or equal to 0.5, if LDH ratio is going to be less than or equal to 0.6, or the fluid LDH only is going to be less than 200 international unit per liter, then that is suggestive of transudative effusion. Next slide, please. Okay, during the chemical analysis of that fluid, the glucose is usually less than 60 mg per dl in case of malignancy, rheumatoid disease, and tuberculosis. And for the tuberculosis, we can also look for the pH. If there are many small lymphocytes and a pH less than 7.2, then that is again the suggestive of tuberculosis. And as we already discussed, that the fluid of serofibrinous pleurisy is clear or slightly cloudy and contains relatively few leukocytes and occasionally some erythrocytes only. Okay, now if bacteria are present on gram staining, and if the pH is less than 7.2 of that fluid, then the culture of fluid must always be performed. In pneumococcal empyema, the culture is positive in 58% of cases. And in patients with negative culture result for pneumococcus, the pneumococcal PCR analysis is most helpful to making a diagnosis. And the blood culture may be positive and have a higher yield than culture of the pleural fluid. And we can also see the leukocytosis and the elevated sedimentation rate may be also found. Well, talking about the complications of empyema, so if the empyema is going to be occurs because of staphylococcal infections, then bronchopleural fistula and pyopneumothorax commonly develop. Other complications also include like purulent pericarditis, pulmonary abscesses, peritonitis from extensions through the diaphragm into abdominal cavity and result in peritonitis, and sometimes osteomyelitis of the ribs, sternums, or thoracic vertebra. Septic complications such as meningitis, arthritis, and osteomyelitis may also be occur. Septicemia is often encountered in H. influenza and pneumococcal infection. That is, meningitis can be occur as complications, the arthritis can be seen, osteomyelitis can be happen, and the effusion may organize into thick pill, which may restrict long expansions, long infection, and may be associated with persistent fever and temporary scoliosis, which is occur in the third stage of that pathological conditions where there is organizational phase. Now, talking about the treatment. So as we already gone through the all the radiographic feature, we did chest X-ray, we did USC, we just got to know that there is a fusion. Then we differentiated that between the cerebrofibrinosus pleurisy, or that is the empyema or chylothorax or pyothorax. So differentiating all those things through the laboratory investigations and like getting done all the cultures and getting the specific cause behind that empyema, that collection of pus, either that is related with some bacteria or virus or TB. So what is the cause of that? After getting all those things done with the laboratory findings, now we will move towards the treatment. And the main aim of empyema treatment is to sterilize the pleural fluid and to restore the normal lung functions. And the treatment includes now the systemic antibiotics and thoracentesis and chest tube drainage initially with a fibrinolytic agent. Most of the cases which I have like seen in hospital setting, that the first stages, which is in just first stage exudative phases in pathologically, if that is in exudative phase, then the systemic antibiotic, thoracentesis and chest tube drainage initially work very good. And if no improvement occurs, then we have to go to the video assisted thoracostomy surgery indicated. And even if after the systemic antibiotic, the chest tube drainage, the thoracentesis, if after doing the VAT surgery, if the patient is not improving, then we can go for open decortications. If empyema is diagnosed early, antibiotic treatment plus thoracentesis achieves a complete cure. As I have shared my experience earlier, that I have gone through, I have seen lots of cases like that. The selections of antibiotics should be based on the in vitro sensitivities of the responsible organisms. Now, when pus is obtained by thoracentesis, the closed chest tube drainage with fibrolytics is the initial procedure followed by the VAT. And if there is no improvement, which we have already discussed, if there is no improvement, so multiple aspirations of the pleural cavities would not be attempted. But if pleural fluid septa are detected on ultrasound and fibrinolysis is attempted followed by VATs, if no improvement is noted, then closed chest tube drainage is controlled by an underwater seals or continuous suctions. Sometimes more than 1 TB is required to drain loculated area, or closed drainage is usually continued for 5 to 7 days, and chest tube that are no longer draining are removed. And even after baths, that's not going to be removed. Then we have already discussed that we are going to do the open decortications for that specific cases. Now here, talking about the extensive fibrinous changes may take place over the surface of the lungs owing to empyema, but they eventually resolve. In the child who remains febrile and dyspneic for more than 72 hours after initiation of therapy with intravenous antibiotics and thoracostomy tube drainage. Now this, again, the same thing we are going to talk here. The surgical decortication via BAT, or less often, open thoracotomy may speed the recovery. And if there is going to be form of pneumatocells, so we should not attempt to aspirate or to treat them surgically. Sometimes the pneumatocells will resolve as spontaneously with the time, but unless the pneumotocell is going to be like embarrass the respiratory movement or become secondary infected, so at that time the long-term clinical prognosis for adequately treated empyema is excellent, and flow-up pulmonary function studies suggest that residual restrictive disease is uncommon with or without surgical interventions. Now here again, talking about the case,